of Kerala chapter IFS. Sir has many publications to his name. Today, sir is going to speak on a very important topic which holds very great relevance when we talk about the practice of reproductive medicine, that is male infertility. I welcome you, sir. Over to you.
One second. Okay, I cannot on my video. Ashita, can you hear me?
Yes, sir. Sir, the host will enable it. Just a second. Yes. Mr. Hitesh, kindly enable sir's video.
Ma'am, it's done now. So can share the screen now.
Okay, thank you.
Okay. Yes. Okay. Good evening to all of you. I think it's audible.
Yes, sir.
Yes, sir.
Let me start sharing.
Oh.
Can you start?
Yes, sir.
Okay. So today's our topic will be on approach to male infertility problems. So I'm Dr. Fessy Lewis. So I think nowadays the importance of male infertility. Hello, is it clear?
Yes, sir. Audible.
Okay. The importance of male infertility is because if you look into different studies, nearly 1/3 of the cause of infertility is because of male factor alone, and 1/3 is female, and 1/3 is combined factor. Or in some studies, if you see as a couple together, there is nearly 30 to 50 percentage is 30 to 50 percentage is a reason for male is a reason for infertility. So 15% of the couples suffer from infertility. Out of that is this 30 to 50 percentage. So the importance is that we must approach the infertility problem. Even though if you are a gynecologist, you must approach as a couple. As a couple only, we must be approaching the infertility. If the female comes, usually we must discourage that. We must, whatever it may be, whether a semen analysis is done or some analysis or some tests they will be showing, but you must see the couple together, because a lot of things is important for that. And the importance is 5 to 10% of the males are infertile or subfertile. So this is what I was talking. Different studies scored a different way, but this is one I got from a study. So nearly for 50 percentage in most of the studies is male is some way is attributed to that. So before going anything about the male infertility, just like female, where we go for a hypothalamus pituitary ovarian axis. Here we must look for a, wait a minute. Okay, we must look for the hypothalamus pituitary gonadal axis. That is most important. In the female, just like that, where is HPO axis, we must look for a hypothalamus gonadal pituitary gonadal axis is important. Here from hypothalamus, GnRH is produced in the pulsatile fashion, and when that GnRH is produced in a pulsatile fashion from the pituitary, FSH and LH is produced, and FSH stimulate the Sertoli cell in the testes to produce the mature sperm, and LH stimulate the Leydig cells to produce the hormones level has to be usually maintained with that. So that is the importance of the for the HPO gonadal axis. So this is more of a pictorial representation of the same. That is, GnRH is produced in the pulsatile fashion, and FSH is produced, which FSH produce the seminiferous tubules and Leydig cells by the LH will produce the testosterone. And this is important because this testosterone plays the negative feedback effect, and that's controlling the production of the HPO axis, HPO HPG axis is being controlled. So the sperm production, usually, as you know, it occurs in the testes and it passes through the epididymis, and from there it passes and through the vas deferens, and it comes through the ejaculatory duct and pass into the penis, and that is how the sperm transport takes place. So, what can be the cause of the male infertility? There are several studies quoted differently. I'll be first quoting one study, and afterwards, in one discussion, we'll be showing the different study. According to this study, there is the most important cause is 35% is the varicocele, and idiopathic also 25%. Also, there can be infection, genetic causes, which is usually 10% each. Endocrine cause rarely, immunologic obstruction, developmental lifestyle factors like smoking or heat exposure to the heat, or some diet can be there. So, as I told, when the infertile couple comes, history is the most important, and they has to be seen together. History means we have to, in the male, we have to, when we see, it must be the duration of the infertility, what is the, whether there was any history of previous pregnancy in that marriage, or if it is a second marriage, or the previous marriage, what was any developmental abnormalities there in the male, and any associated medical or surgical history relevant, is there a patient is taking any medicines for any other disease, or any surgery has been done, and sexual history, whether what is their sexual frequency, or what is there any difficulty in erection, difficulty in ejaculation, and whether there any family history of any diseases. This is the main part of the history. And next comes the physical examination. And physical examination means the patient has to be properly examined, and then comes the semen analysis. And only in indicated patients you have to go for endocrine tests, and only indicated patients you have to go for a genetic test like karyotyping or Y deletion. And the last, if needed, only surgical evaluation like testicle biopsy or antisperm antibodies, which is not found to be any clinical importance now, because even if antibodies are there, that is being when you do the IUI or IVF, that will get corrected. So we will deal with that separately, each one of them. So coming back to the development of childhood history, the most important is that bilateral, if there is any history of undescended testes, there is any history of torsion testes for which undergone any surgery or not, or sometimes they will be having testicular torsion history, pain associated during any injury during riding a two-wheeler, or playing playing, some history of testicular torsion will be, they may not have undergone surgery also. And whether there is an history of mumps. Mumps means if it is associated with orchitis only, it is important. and herniorrhaphies, that hernial surgery, when was the onset of puberty, when was the onset of secondary sexual characters. That can be easily seen by looking to the onset of the axillary pubic hair when it was started seeing on this, when the boy started shaving. And medical history, most important, the systemic illness like any hepatic or renal failure history, any gonadotoxins or toxins, drugs he is taking like sulfasalazine, cimetidine, nitrofurantoin, or chemotherapeutic agents or anabolic androgens boy is taking or male is taking, or any thermal injury, whether it is associated with smoking, alcohol, or any abuse drugs is taking. And surgical history, even though initially I told herniorrhaphy, must also look for other history of any orchidectomy, retroperitoneal surgery, or bladder neck surgery, or there is which usually can lead to retrograde ejaculation. Sometimes there will be an ejaculation, but the patient will be having orgasm during masturbation or sexual intercourse. That will be the only history for the retrograde ejaculation. So that's what we have to clearly see. And physical examination, next part is that how the general appearance is, whether there is in the examination there is any gynecomastia is there, and how the axillary pubic hair is there, and whether there is testis on examination, what is the volume, what is the consistency, and epididymis, whether there is cyst is there, when induration is there, or fullness is there, and if there is varicocele, that has to be seen in the patient, has to be examined in the standing position, and we have to see the impulse on cuff, was whether it is palpable or not, and if in doubtful cases, we have to go for a digital rectal examination. Coming to the clinical examination, the testis, we have to see whether the testis, as I told, consistency is there, whether how the size, that is whether it is extremely significant, if it is a small testis and soft testis, epididymis, especially if it is distended, and vas, whether if it is absent or thick or bearded. That is the thing what we have to be clearly seen. And this picture I just put to show that how the test to show how the when we are feeling how the testis will be, how the epididymis, how the vas is felt. So this is the normal anatomy of the male reproductive system. And along with that, in clinical examination, even though it is really important, which usually people will be forgetting to see, is that whether there is any associated phimosis, paraphimosis, or hypospadias. Just simple examination that is enough to know that. And even though it looks less relevant, okay. Can you hear me?
Yes, sir.
Okay. So next we had to see whether the, as I told, testis consistency, whether epididymis is along with that we had to see for phimosis, paraphimosis, and hypospadiasis, and vas, whether discontinuity is there, whether bearded, whether it is thickness. Sometimes even one side unilateral vas can be absent. So that is we have to see. And also in addition to varicose, we have to clearly see the whether there is associated hernia is there, hydrocele is there. This is simple clinical examination. When you are practicing infertility, even if you are male or female, you can, if you start doing it, only there will be initial, there will be, if you will not be, if you, there will be slightly, we may not be used to it, but once you start doing it, it has to be routine. If you are not comfortable, then you can ask, send to the any urologist, but preferably it is the thing which that orientation must be there for if you are a infertility specialist. Even though you are male or female, we have to start doing this clinical examination of the male partner, has to be part of that, of what of the initial clinical evaluation. Coming to the investigation, important is that semen analysis. That's the most important. And if you tell the any other things which is important, whether examination is the blood sugar examination, either the routine RBS or the HbA1c. And if you see for any one blood test hormonal, that is FSH, karyotyping and Y deletion, and the postcoital test. I just put it to highlight the other important, but the most important, the only thing needed initially for infertile patient is the semen analysis alone. And coming one word about the postcoital test is that even though there are some studies from the RCOG telling that postcoital test is not statistically significant, but I routinely do postcoital test because that make sure the couple is having normal intercourse. And if you see good sperms in the cervical secretions after 2 hours and before 12 hours of post intercourse, and that makes sure that the male factor is almost less, because there is no sexual problem. They're having normal intercourse and sperm is surviving, so that the chance of more sperms going into the uterus is good. So we have to think more about any mechanical factor which is preventing the fertilization, or any ovulatory factor which usually affect in that couples. So semen analysis, it is usually collected after 2 to 7 days of abstinence, evaluated within 1 hour of ejaculation, and examined 2 to 3 samples to obtain the baseline parameters are abnormal. So this is very important, and preferably according to the people, now we are following the WHO 2020. Previously it was WHO 2010. I'll come to that separately. So there are multitude of methods available, but it is of utmost importance to follow the WHO criteria for uniform reporting, because that is how the standard criteria has been usually universally followed. And assessment of morphology need rigorous training, strict figure criteria to be used to assess morphology. That is the usually people follow that, but it's slightly different from morphology criteria by the WHO. I'm not going to that detail. So this is the 2010 WHO semen analysis, where the normal is between 2 to 6 ml, count is above 15 million per ml. That is a concentration. Motility is more than 50% with vigorous forward movement in 2 to 3 hours, and motility is grade 2 or above, and morphology is more than 5%, and with not significant agglutination, not significant WBCs in the semen sample. So there was one problem with 2010. Its reference values are lower than the previous release value, and they took 2,000 men where the time to pregnancy was less than 12 months. But and the lower reference limit according to 2010 is that at least 15 million per ml or 39 million per ejaculate, a total motility of at least 40%, progressive motility of 32%, and normal morphology at least 4%. That is important, because if you see a semen analysis report with 60% or 70% normal morphology, that means they are not stained the sample, they are not done properly. And the main problem with the 2010 is that they not include the Afro-Asian population. And this is what I was telling, when you compare with the previous values, there is a gradual shift of a normal semen concentration from 20 to 15, and total motility also from 50% to 40%, and that include, as I told previously, that does not include the Afro-Asian population in 2010. So the what latest which came is the WHO sixth semen analysis manual, that is 2010. And this is how the manual kit is available online. So it is little complex. You have to read thoroughly, then only you will understand that. And if you compare with the 2010, there is not much difference with that. And what the basics of the was the lower fifth percent, that is with 95% confidence interval of the 7 parameters from men in couples starting a pregnancy within 1 year of unprotected intercourse, leading to a natural conception. That was the basis of both the 2010 and 2021, the fifth and sixth edition. If you look separately, there is only a very less difference. Almost it is comparable, except for the slight difference. Here also some people of the all over the world was not included, but it has included a few of the Afro-Asian population also were included. This is how the WHO different. This is how the previous WHO manuals how they are published. This is 2010 manual. This is 1999. Before that was 1992. Before that 1987, and first was in 1980. So let us see the what was the sort what things what that means strength, weakness, and opportunities and threats of the salmon analysis. The main weakness was data of the fertile men from some geographical such as South America, Sub-Saharan Africa are still underrepresented even in the sixth one, and lack reference threshold for decision intervals to replace the fifth percentile of the basic salmon parameters, and lack of indications and criteria for interpretation of sperm SDF testing, that is linear fragmentation, and lacks cutoff threshold values for extended sperm analysis such as SDF test. And the main strength is that extensive data of humans were in the sixth edition provide important insight into the global management of male infertility. That is one of the main strengths. So this just I just put sort of the thought provoke that there was some strength and weakness in that, and the main opportunities that further research and in subsequent years we can come out with more data, especially with the other tests associated with the seven parameters. So when we look into the criteria, whether you are following the 2020 or 2010, you must exclude any recent febrile illness and more than one analysis when abnormal. This is important. This points is the thing which we have to be really careful in when analyzing the semen analysis. The abstinence of 2 or 3 days according to the sexual habit and never more than 5 days. More and more dead sperms you can get if the abstinence is more than 5 days, and there must be suitable surroundings for masturbation, not preferably not in a bathroom. Proper room has to be given, and there must be a dedicated lab and technician who are skilled in that, not to be analyzed along with the other blood, stool, or any other urine or anything. It must be separate lab. Always stain the sample to differentiate the pus cells and also assess the morphology, and give more importance to motility and morphology rather than the count. That is the main important crux of the semen analysis. So the most important is that we must be always know that if a suspect patient's diagnosis must be confirmed by the lack of any spermatozoa on centrifuge seminal fluid on 2 separate occasions at high-powered microscopic field evaluation. In WHO recommends centrifugation for 15 minutes at 3000 G or greater before coming into, that is a centrifugation speed. So and always you must be always know that semen analysis authority based, normal parameters. Male can also be infertile, and even if it's severe oligosynodarpaspermia, patient can be fertile, and infertile to one female can be fertile to the another. So this is how the normal semen can be. And if you look, what are the main things what we are seeing in the semen analysis? One is the semen count, sperm count, and the other is sperm morphology, that is how the morphology of sperm, and then is the motility. These are the 3 main things what we are seeing. And this is just one picture of in the semen analysis. One patient, almost 90% of the sperms had more than 2 tails. That is one one thing where we have to suspect of a genetic abnormality. This we got few years back. That's why this picture I have put here. So, what are the nomenclatures of salmon? It is normozoospermia. If the definition is normal ejaculation based on concentration, motility, and morphology of sperms. Oligospermia, the concentration of the sperm is less than. This definition is according to the old 19 by the fifth edition of a WHO analysis. Now it has to be less than 16, and severe oligospermia if it is less than 3, and astenospermia if the motility is less than 50 percentage, grade A and B, or grade A motility if less than 30 percentage, and teratospermia if the morphology is less than 30 percentage, oligogastric teratospermia if there is defects in concentration, motility, and morphology of the sperm, azoospermia if there is no sperm in ejaculate. The specific definition we already discussed. Aspermia if there is no ejaculate, hemospermia if there is red blood cells in the ejaculate, biospermia if there is white blood cells in ejaculate and concentration of less than 1 million per ml. So next is that of salmon analysis, endocrine evaluation. Whether it is done to be routinely for all patients, no. If it is indicated if the salmon concentration is less than 10 million per ml, and if there is associated erectile dysfunction, if there is hypospermia, that is semen volume is less than 1 ml, there is signs and symptoms of endocrinopathies or hypogonadism also. These are the indications of doing of endocrine evaluation indications in the male factor infertility. And the three important, if you tell one hormone alone important, that is FSH. If you see the routine hormones needed is FSH, LH, and testosterone. And usually it is normal for normal semen analysis, or if there is obstruction, also it can be normal. And if it is testicular failure, FSH will be more, LH will be more, testosterone can be normal or decrease. And most important is that hypogonadotropic hypogonadism, where FSH will be less, LH will be less, and testosterone will be less. This is the thing what we have to be always looking to, because the management is totally different. And isolated spermatogenetic failure is usually rare. And coming back to the FSH, I told you this is the single hormone which is relevant. If it is less than 3, that is hypogonadotropic hypogonadism. And if it is more than 8, that is compromised testicular function. Usually between 3 to 8, it is testicular function is normal. And usually in oligogastric teratospermia, especially with high FSH, that implies the testicular function is compromised and assisted reproduction technique has to be advised. So coming to the major causes of, if you look at the causes of male factor infertility, it can be pre-testicular, testicular, post-testicular, and also it can be sexual dysfunction. So if you look at pre-testicular, this theoretically completion say we have to look in about the hypothalamic disease, like gonadotropin deficiency, like Kelemen syndrome, or pituitary disease, or pituitary insufficiency, like tumors, radiation, hyperprolactinemia, or exogenous hormones like anabolic steroids, glucocorticoid excess, hyper or hypothyroidism. And testicular, it is can be congenital, like chromosomal Klinefelter syndrome, by chromosome microdeletion, or very rarely Noonan syndrome, Turner syndrome, that is 45X0, or cryptocradism, or it can be occurred like injury like orchitis, torsion trauma, or severe varicocele, or systemic disease like renal failure, liver failure, or any chemotherapy, radiotherapy, testicular tumors, or idiopathic rarely. Post-testicular congenital, that is that is congenital absence of vas deferens, that is associated with usually with cystic fibrosis. It can be associated very rarely young syndrome, that is very rarely, and acute can be due to the vasectomy, or rarely through the infection like chlamydia and gonorrhea, or iatrogenic vascular injury due to any surgery or any hernial surgeries. Disorders of sperm function motility like immotile cilia syndrome, maturation defects, immunological infertility, or lobocysteemia. So this is what I told. This is what I told initially that about the different etiology of the male factors is another study where the idiopathic forms the 75% of causes and 12% is due to varicocele and this other causes. I just put it separately so that different studies uh, tells differently, and out of that most important is varicocele and idiopathy. So if there is varicocele, we have already seen both the studies. Varicocele is one of the two major causes. It is significant if there is severe clinically palpable varicocele rather than the ultrasound. If there is clinically palpable varicocele with may affecting 7 parameters, that is the large varicocele with the oligosynovial. Then we have to go for a subinguinal microscopic surgery. That is the most accepted. And usually the FSH will be normal and testicular size will be normal usually. Very rarely only FSH. Some isolated cases you can see with increase slightly elevated FSH and affecting the testicular size. But usually FSH will be normal and testicular size will be normal, and subinguinal microscopic surgery gives the better result than any other method. And scrotal ultrasound we can do to assess with Doppler, we can assess the testicular volume, assess the varicocele and testicular associated testicular tumor, and transrectal ultrasound to identify the dilated ejaculate ducts in obstruction we can do. But for varicocele, clinical assessment is the most accepted and most accurate thing. So other surgical treatment, what we can offer for male factor infertility, say in vasectomized men can go for vasostomy or vasectomy. It is a lengthy procedure, time consuming, and the results also only very few people are skilled to do it, and that is now the importance has come down with the advent of IVF procedure like ICSI. Importance has come down. And next is that transurethral resection of ejaculate duct resection in men with ejaculate duct obstruction, which is very rare. Varicocele, where we already discussed, and in medicine we had to go for orthodox at the earlier age in the childhood, it's less than for 2 years. And if there is neurological dysfunction, you can go for vibrator stimulus or electroejaculation to retrieve the sperm. These are the common surgical technique treatment what we have to know about and what we can suggest to the patients with male infertility. So coming separately to the azoospermia, we already discussed the definition, WHO definition. Even if no sperms is seen even in the centrifuge sample, 2 occasions, preferably 46 weeks gap, even centrifuge at 300 varies, and it can be also due to 3 types: pre-testicular, testicular, and post-testicular. Post-testicular means it is obstructive. And the most important thing we have to differentiate whether we're dealing with the oligosynovial or azoospermia is that whether there is any it is due to the hypogonadotropic hypogonadism. Here the as I described in the FSH chart, FSH will be less than usually 3. And the LH also will be less. I will show the FSH, LH, and testosterone values. And the testicular size can be normal or low. And in here also, in azoospermia, also the obstructive azoospermia, usually the testicular size is normal. FSH will be normal. Non-obstructive azoospermia, testicular size can be normal or reduced. With high FSH, and testicular function is usually compromised. So this here in hypogonadotropic hypogonadism, the treatment is to give hormonal treatment that we have to give HCG injection, 2000 or 5000 units every 3 to 5 days for the initial 1 to 2 months. And when the HCG stimulate the production of testosterone from the Leydig cell, we have to add along that HCG HMG injection that will stimulate the seminiferous sperm production in the patients with hypogonadotropic hypogonadism. The importance is that whether it is if it is an azoospermia patients with hypogonadotropic hypogonadism, if you advise hormonal treatment, patient has to take the injections for near minimum of 4 to 6 months. And at the end, there may not be any sperms. Sometimes the patient can get few sperms. That is enough to do the IVF procedure, ICSI procedure. That is the importance. And if you give hormonal treatment in hypogonadism, the most important is that patient has to take the injections for a longer period, and the cost itself is very high. In which minimum of, I said, 12 for 6 months we have to take. Then you may get enough few sperms enough to do the ICSI procedure most of the time. That is the thing we have to counsel before treating the patient with hypogonadotropic hypogonadism. So otherwise, if it is obstructive azoospermia or non-obstructive azoospermia, not in hypogonadism, obstructive or non-obstructive azoospermia, you go for testicular biopsy. And in obstructive azoospermia, if you get from the epididymis, that will be that if you get good number of sperms, you can get. If not, from the testicular biopsy, you get the sperm, you can go for a IVF ICSI procedure in this patient. So this is what we already discussed. Testicular emissions, testicular failure also we discussed. Here, I just put it separately because testicular failure due to varicocele and orchitis is very rare, but it is not. I mean, even though it is rare, it can occur in severe varicocele, long-standing, or severe orchitis. Sometimes we can get testicular failure. That's why I just put it separately. Obstructive, it can be due to epidermal obstruction, vas obstruction, and commonest is the congenital bilateral or unilateral abscess of vas different. And next thing is that post-surgical either hernia or spondyl surgery or even vasectomy. We have to take the history. Nowadays, the incidence is few years back, the incidence were very high, and ejaculatory tract obstruction is very rare. And the importance is that if you in the obstructive azoospermia, if you can get the sperm from the epididymal sperm aspiration or by the testicular aspiration, we can do the seeing that in obstructive azoospermia most of the time sperms will be genetically normal. Except for congenital bilateral absence of vas difference, where the CFTR gene mutation can be inherited. So I'll come to that. So when usually if you can retrieve the sperm, it's the intracytoplasmic sperm insemination. Cytoplasmic sperm insemination is the treatment, and usually it is the most ideal case for a assisted reproductive technique because sperms are usually genetically normal, structurally normal, and patient comes early. This just to diagram to show how if there is any obstruction or absence of vas, we can retrieve the sperm from the epididymis or the testis. That's why it is being shown here. And if it is a non-obstructive azoospermia, usually the testes are small or soft. FSH is usually in the upper limit or high. And they usually go for an HP. Usually the testis, the report can be atrophic testis, Sertoli only syndrome, maturation arrest, or hyperspermatogenesis. But if you can retrieve the sperm, usually in the 30 to 50% of the non-obstructive azoospermia patients, most of the studies we can retrieve the sperm, and then we can go for an ICSI procedure in the. So how do you retrieve the sperms in azoospermia? We can go for PISA, that is percutaneous epididymal sperm aspiration. Usually local anesthesia with sedation or regional block is enough. We can use a 19G needle attached to the 10 ml syringe for suction. It is a simple OPD procedure. It is expensive and effective procedure, and there is no incision, no microsurgery experience is not needed, and it is a blind procedure. You can see how the sperm is. You can use the butterfly or even the insulin syringe with media is enough to retrieve the sperm from the epidermis. And even though it is simple procedure, here also you can get a complication like scrotal hematoma can occur if you not do properly. The next is that percutaneous testicular sperm aspirate, that is TISA. Here we are using to get the procedure is to use to get the sperm from the testis. Local anesthesia with sedation or regional block. Here a scalp vein set of 18 G is usually used with the 20 ml syringe to give a negative pressure. Removing the intact seminiferous tubules and its content and examining under the microscope the andrologist or the andrologist will tell you whether the sperm is obtained, and there is no incision or microsurgery procedure is experience is required here also. But in non-obstructive spermia, usually FSH level is increased, and the size may be normal or less than normal. And if you don't get by the TISA procedure, then only go for the testicular sperm extraction. And usually the procedure nowadays with good result is the micro TISA, that is microscopic testicular sperm extraction, that is TISA. Here the principle is that under the magnified using a operating microscope, you see the appearance of the seminiferous tubules by seeing the diameter. You identify the site of production and preserving the testicular vasculature, small quantity of the tissue is excised, which is being routinely hydrated with hydrated. And the evaluation of the testicular parenchyma is done, and the microdissection is done, and the area of tunica albuginea is incised and microdissected. And if doubtful cases, we incubate that, and then we incubated in the incubator and seen under microscope. And next thing is that genetic disorders. What is association with male infertility? Knowledge of the genetic abnormalities in infertility is mandatory, so that the correct advice can be given to the couple seeking fertility treatment because of male infertility. This is one survey of 11 publications, including nearly 10,000 infertile male. The incidence of chromosomal abnormalities was 5.8%. Of the sex chromosome abnormalities account for 4.2, and autosomal abnormalities for 1.5% of those patients. What usually is genetic abnormalities is in Klinefelter syndrome is the most frequent sex chromosome abnormality. Adult men with Klinefelter syndrome has small firm testes. Cystic fibrosis, which is a fatal autosomal recessive disease, is one of the most common genetic disorder associated, especially with the absence of mass difference. And standard karyotype analysis should be offered to all men with damaged spermatogenesis who are seeking fertility treatment by IVF Fessy. Genetic counseling is mandatory in couples with genetic abnormality and in patients who carry a potential inheritable disease. So in patients with severe orgasmotarcospermia or azoospermia, we have to advise karyotyping and Y chromosome microdeletion. That are the most of the European countries, if you are doing IVF procedure, see for a severe male factor infertility, karyotyping and Y deletion is compulsory. The importance is that if there is a chromosomal abnormality like this, in this you can see a XSY, this same chromosome get inherited into the subsequent offspring, and if there is a Y chromosome microdeletion, this is a Y chromosome. Microdeletion can be SNF-A, SNF-B, or SNF-C, that are the microdeletions in the Y chromosome. And if there is that deletion, if the subsequent child is a male child, that same Y chromosome will get transferred to the subsequent male child, and same male factor infertility can be inherited to the subsequent child. That is the importance of the genetic studies in of karyotyping and Y division in severe male factor infertility. So the other importance of Y chromosome microdeletion is that indirectly reflect the how the chance of getting the sperm in severe ZFA abnormalities. Usually the Sertoli and only syndrome, the chance of getting sperm is almost nil. ZFC, it is a mild form, you can retrieve the sperm. ZFB or a combination of ZFB plus C, maturation arrest and azoospermia, sometimes you get the sperm. So some people follow the pattern. If there is azoospermia, go for a microdeletion, then plan for the treatment. Usually also so that results in the helping the counseling the patients. More important is the subsequent offspring. If it is the same Y chromosome, will get transferred to the subsequent offspring. So that is the importance of SNF-A and B, and SNF-C. We can retrieve the sperm in 70%, and SNF-A it is almost nil. SNF-B sometimes we can get. And coming to the management of male factor infertility, medical management, you have to always rule out any thyroid associated thyroid problems. If thyroid deficiency, you have to supplement with that. And if there is prolactin hormone, prolactin, high prolactin is there, you have to give dopamine agonist like capricorn has to be given. And this is, I just put it separately to highlight the hypogonadotrophic hypogonadism, whether it is azoospermia or severe male semen abnormality. Usually, we have to first give for 2 months HCG 2000 or 5000 unit twice weekly, which stimulate the Leydig cell to produce testosterone, testicular testosterone, followed by HCG plus HMG, the human menopausal gonadotropin 75 unit twice weekly. And the only thing is that we have to counsel. The whole treatment will take nearly minimum of 4 to 6 months, and only you can get result before starting this costly treatment. We have to counsel the patient. The second half, that is HCG plus HMG, stimulate the pituitary to produce the LH and FSH, stimulates the production of the sperms in the when the local testosterone production, which is been stimulating the sperm production. And people initially tried pulsatile GnRH using the pump, but it is very expensive. It's not practically done anywhere. What is the role of anti-estrogen therapy? Anti-estrogen therapy, initially people had tried clomiphene citrate in tamoxifen for 3 to 6 months. It blocks the estrogen receptors in hypothalamus and pituitary, which increases GnRH, releases FSH and rest from the anterior pituitary, which stimulate the sperm production. But when you give clomiphene citrate, especially, there must be usually a gap of 5 days after 25 days, so that it will negative feedback effect will stimulate. But there is many people who routinely don't give clomiphene citrate for normal semen abnormality. Even I don't give that. But there are few studies come now when we have to do the testicular, which I've been doing for last 2 years. We had to do the testicular estradiol level, and if the testicular estradiol ratio is less than 10, that means if the estrogen is high, in those patients, if you give anti-estrogen therapy with the letrozole, that will suppress that estrogen level and stimulate the sperm production only in patients with the testicular estradiol ratio less than 10. That means especially in obese patients with azoospermia or severe male factor infertility. Then you will be seeing that its market is flooded with the fertility enhancing nutrients, L-carnitine, coenzyme Q10, lycopene, selenium, zinc, vitamin C, so these all are antioxidants. Antioxidants. So how does that help? Is that It increases in concentration, motility, and vitality, and sperm morphology parameters in some patients. So it is worth trying in few patients, especially if they cannot afford the, especially if they cannot afford the for the for the IVF treatment. And nowadays, if the DNA fragmentation, if it is high, there is a role to try for antioxidants. But there are some studies telling it is questionable whether it is really effective or not. So one possible theory is that it reverses the oxidative stress in male infertility, especially the oxidative stress in male infertility. It can be due to varicocele infection, endocrine reason, or any development or lifestyle reason. So this will be reversed to some extent by giving antioxidants. So there are some studies supporting that if there is increased ROS level because of the oxidation and stress, that will affect the sperm function. So if you give the and if that ROS production is increased, there is degradation of the sperm. So when we give the antioxidants, usually that increases the reduce ROS level and the sperm function is being improved. That is the main principle of giving antioxidants for male factor infertility. Then, if there is any infection, and if you're seeing pus, especially if you are staining the semen and seeing if the pus level is more than 1 into 10 raised to 6, that is 1 million, there is a role for antibiotic therapy. And if the value is high, more than 1 million per ml, we have to give for cultural sensitivity and give the antibiotics per se. And some people give cyclical antibiotics with prostatic massage because that will increase the vascularity of the prostate and affect, especially the antibiotic WC count is more, which is resistant to the routine antibiotic therapy. And lifestyle modifications like cigarette smoking and other thing has to be reduced in the patients with the persons are more. So coming to DNA fragmentation, there are a lot of papers supporting that. What is found is that if the DNA fragmentation is more, it will affect the sperm function. In those patients, we can advise antioxidant therapy and air-to procedure at the earliest. So the situations with the DNA fragmentations, there is infection, inflammatory genital tract, or if there is varicocele, testicular maldesign, impairs, if there is associated, patient has history of radiotherapy or chemotherapy, exposure to the heat and chemical products, and rarely idiopathic also. And one word about computer-assisted sperm analysis. It has been developed to improve the accuracy, to remove the subjective effect influence of the semen analysis. Because it is more, computer is more objective, but it is not reliable if the sperm density is less than 2 million or if it is more than 50 million, and if there are a lot of debris or immortal sperms is there, we need to dilute the semen and to the CASA, and it is an expensive tool. Coming to the other than medical management per se, the other management is one is the intrauterine insemination. Previously, people were doing intracervical and cervical vaginal insemination, and if very rarely direct intraperitoneal insemination. Out of this, my 30 years of infertility practice, I have done only one case. This patient was not able to afford, that was about 25 years back. Otherwise, nowadays, there is no role for INTP, that is direct intraperitoneal insemination. And whatever be that we are using, we have to prepare the semen sample and do it. Otherwise, the prostaglandin will produce severe uterine contraction when we are using intrauterine. And when we are doing intrauterine insemination, usually it is done by the non-sexual factor. If you are doing intrauterine insemination, it is associated usually for a control over hyperstimulation, so that we are stimulating the ovaries produce good sperm, a good ovum, and we are bypassing the vaginal motility, and concentrated good quality of sperms are are deposited nearer to the site of ovulation, that is in the uterus, so that the fertilization occurs in the tube, and we are removing the dead and necrotic tissue, and even the anti-sperm antibodies we are removing by the preparation of the semen sample. Success rate is never more than 15%. Most studies tell it's 10 to 15%. That is the thing we have to consider. We must not give false hope to the patient. Never useful if the count after preparation is less than 1 million. It is very success rate is very minimal with that. And basic female evaluation must be done before doing IUI. And if you are not doing properly, we can lead to even this simple procedure can lead to pelvic infection. Usually, we are not supposed to use the antiseptic solution for the IUA because it is spermicidal or gametotoxic. So, if you are using cleaning the vaginal cervix with saline, and if you are not doing it properly if you are not doing with the proper aseptic preparation, can lead to pelvic infection in this patient. So how do you prepare the semen for IUI? The simple washing technique is there, and simple technique is there. There is density gradient technique is there. I'm not going to that minute detail, but usually if the semen sample is good, the density gradient is advised. Otherwise, the simple technique is better, which is simple cheaper. But most people look for the double density gradient, where the problem is that after doing the density gradient, you have to wash the semen sample again. So the semen sample is bad, the yield will be very bad. So coming to assisted reproductive techniques, there are several techniques. The word IVFET means in vitro fertilization embryo transfer. GIFT means gamete intrafallopian transfer. SIFT is zygote intrafallopian transfer. These two are not done nowadays because that involves invasive procedure to do the laparoscopy to deposit the gamete, so the zygote into the fallopian tube. It's just for completion's sake, I put this for your academic interest. The words as you see means subsonal insemination. C, as you all know, is intracytoplasmic sperm injection. H is assisted hatching. IVM is in vitro maturation of oocyte. PGD is pre-implantation genetic diagnosis, all associated with the IRT procedure. The basic technique is that in ICSI, we retrieve the oocyte after controlled ovarian superovulation. That means in controlled fashion, we superovulate the female, and before the follicle structure, we retrieve the oocyte. And when we retrieve, we first in the conventional IVF, we mix the sperm with the we mix the oocyte, that is oocyte cumulus complex with 10 to 20,000 sperms. In ICSI, we first denude the oocyte, that is the oocyte cumulus complex is denuded, and we isolate the oocyte after denuding the oocyte cumulus complex, and we inject the sperm. You can see this oocyte is held with the holding pipette, and the sperm is injected. You can see the sperm inside. We have to avoid the polar body. Make sure we are in the cytoplasm. That is the main difference between IVF and ICSI. So, to sum up, most important is the clinical history followed by physical examination, then semen analysis. If it is normal, sperm function test like being anti-sperm antibodies is not much done nowadays, and basic female evaluation has to be done. And then as always, exclude the other exposure of toxic agents, endocrine evaluation in selected cases, and genetic evaluation, and other tests in specific cases where we have already discussed. If it is asuspermia also, after proper clinical history, we have to always follow out whether there is hypogonadotropic or hypogonadism. This management is totally different. If it is obstructive asuspermia, we have to look for whether absence of VAS, and the most common is CFTR gene mutation, and in congenital bilateral absence of VAS. And if it is non-obstructive asuspermia, we have to definitely do the genetic tests, karyotyping, and Y chromosome microdeletion, and to consider for testicular biopsy. Otherwise, we have to look for the ejaculatory volume If it is normal, we have to go for an we have to depending on the semen analysis, we have to put it. So when there is a male factor infertility, have to take a detailed history, clinical examination, look for any treatable cause, go for a definite treatment if indicated, get the confidence of the patient many times. Just male factor infertility, which is not an unexplained reason or the on borderline reason, usually time will treat in many patients because we have to counsel the patient regarding the what are the treatments available, how the fertilization occur, what is the chance of pregnancy in one cycle. That is most important. Thank you for the question.
Thank you so much, sir, for such a wonderful presentation. It was a very comprehensive overview of male infertility. If anybody has any questions, any doubt, you can ask or put it in the chat box. Sir, I want to ask one question. If there's some
Can you repeat? The voice is breaking. Can you repeat?
Hello, I am audible, sir?
Yes, yes.
Yeah. So, sir, there is a young patient, 28 years old. She has around 10 M2 sites, and when ICSI was done for severe OATS, so there were 3 embryos at day 3. From day 3 embryos. And if cycle gets failed, so do you have any experience that in next stimulation we should do TISA for the sperms, or again we should take the semen sample? Like in some study they say the
Can you tell how many oocyte was there, or what was the fertilization? Can you talk a little loud?
Sir, like 10 M2 sites, ICSI was done for severe OATS. The count was less than 0.5 million. So there were 3 embryos on day 3, and they were grade 2.
How many embryos
on day 3? 3, sir.
Okay. Okay.
So, sir, do you have any experience that in next stimulation, the TISA sample to be used rather than ejaculate?
That is a good question, because usually what we have to do is that we have to basically rule out any genetic abnormality for the male. This happens usually. We don't routinely do in India. Routinely, it is not a mandatory to do any genetic tests in severe male factor abnormality. As I told, no, in most of the European countries that is mandatory. We are not doing it. That is the one thing you have to do. And we can give antioxidants also. And if you do a proper ICSI, the fertilization can be better. But the more confusion is that if you have a total fertilization failure. And there were initially, a few years back, there were some studies telling that you can get a better fertilization, may get with the TISA sample. But there is no further study supporting that. More than that, in TISA sample, the sperms will be won't be mature enough. The mature sperms will be more, so the fertilization problem will be more if you are using that, especially if you can get ejaculated sperm. At least if you get 10 oocyte, if you can get 10 sperms, that is important. But what we have to see is that we have to rule out any genetic reason. And I told now in the last 2 years, there are some papers, not only in azoospermia, severe oligoacidoterpespermia. If there is a reversal of testicular estradiol ratio, That means if especially in obese males, if you give a short course of 6 to 8 weeks of letrozole along with that antioxidant, and then go for ICSI procedure, the fertilization rate is more and pregnancy rate is more. I got a few incidents with that, especially in obese patients. And next thing is that we have to always rule out a genetic problem. Plus, we have to see if you cannot get good sperm in the first ejaculate, we have to go for a second ejaculate on the same day of ovum pickup. So we can use the fresh semen, and the second sample may get good sperms, which you can use for the IVF procedure. About 7, 8 years back, there were some studies about doing IMSI, and that also is not been. Other studies is not supporting to do the intramorphological selection of the sperm for ICSI. There is no larger studies supporting that. So, and it is a much costlier equipment also, so it is cannot be routinely done. So I feel you have to rule out the genetic problem. You have to give antioxidants. If there is a testicular estrogen reversal, then you have to give a short course of anti-estrogen with the letrozole. That will be really useful.
Thank you, sir.
Then the question here I can see in the chat box is that one is FSH if there is more than 30. If with FSH more than 30, you have to definitely correlate it with the testicular size. And if it is a case of azoospermia with high FSH, definitely we have to counsel to go for on the day of ooset, we have to counsel and prepare the patient for TISA. And if you don't get the TISA sample, you have to go for a micro TISA, because higher the FSH value, the chance of getting sperm by routine TISA is less. And even micro TISA also, we can get even with higher FSH, but that has to be correlated with the testicular volume, and we have to prepare to go for a micro TISA in those patients. And which investigation is to be done for diagnosis of site of obstructive azoospermia? Yeah, one thing is that if the FSH is normal, if it is obstructive azoospermia, the thing is that if you can get good sperm from the PISA or TISA sample, we can go for an ICSI procedure. There is nothing we are going to gain too much to know that according to the site of obstructive sperm. If you can get good sperm, we have to go for an ICSI procedure. That is the best. Previously, if there is ejaculatory duct obstruction, if you can diagnose, when people are trying with the urethral resection of the ejaculatory duct, but it's very, very rare. And usually the obstruction, the result is better with the ICSI procedure. Next question is IUI successful in cases of genetic etiology oligospermia? The problem is that if there is genetic cause, the chance of success with the IUI or ICSI will be less, because fertilization can be less, and the embryo quality will be less, and implantation chance will be less, and that success depends on how far is the oligospermia, how bad is the oligospermia, and if there is genetic abnormality, the risk we are worried about this. The genetic cause will be transmitted to the subsequent offspring. That is the thing which we have to be, which we are really worried about. Next question again from Pooja is: does medical manager help in patient with oligospermia due to genetic cause? Genetic cause, if it is there, definitely we have to counsel the patient about the what sort of genetic condition is that, how far it can transmit. So just by medical management won't be enough for those patients. Question. Rectal dysfunction, medical treatment. Then if there is a rectal dysfunction, first we have to know what is the real cause of rectal dysfunction. Most of the time, patient comes with a rectal dysfunction. 50% of the patients will be due to the female reason. Suppose the female wife is having vaginismus, that may be the reason for the initial rectal, penetration problem, which they will have reflect as a rectal dysfunction. Because once the male get conscious about the erection, it is a cyclical process. Next time when they try to have intercourse, they will be thinking more about conscious about the erection, and if we are conscious, male will loses the erection and very fast. So it will be cyclical process. So if there is a problem in initial penetration, so that we have to see the history whether the initial there was whether the couple had a any sexual problem, or started afterwards. And definitely if it is a delayed onset, we have to rule out any diabetes or other organic reason or any medicinal history. And in detail history, we have to see whether male can have normal erection, normal masturbation, whether there is any this rectal dysfunction is only was there, whether in the previous any experience of the sex, whether the male had this issue. So looking into that history, we have to advise the treatment, and the couple has to be seen together and separately. And again, we have to see the female also has to be examined to see whether there is vaginismus. If there is vaginismus, we have to treat the female to correct the vaginismus. Then again, treat the couple together. Then most of the time, the erectile dysfunction can be corrected.
Now, sir, there are no other questions in the chat box. I think we can conclude here. Thank you so very much again.
Okay, thank you, IFS chapter Madhya Pradesh, for giving me opportunity. Thank you. Can I leave?
Yes, sir. Sure, sir.